When those sectors downsized, a lot of those people who used to work in that sector, basically the parents of the kids that I grew up with, they had to turn around and get jobs that paid them less money, and they didn't have health care coverage. So what ended up happening was that they were they had jobs, but they were like what you would call, for lack of a better term, working poor. They're making a little bit too much money to be eligible for Medicaid, but they weren't making enough to purchase health insurance out of pocket. And so they were caught in the middle. And so I wanted to do something about that this is a long time ago, when I was in my 20s, and I worked on setting up a health clinic for working poor people with no insurance. And we did that for a couple of years. It was the most rewarding experience that I've had in my life, but wasn't paying myself a salary. So I eventually had to get on with life and to do something because I wanted to get married, and my wife didn't like the idea that it wasn't making a salary. So I went to grad school at Hopkins, and I went there with so much vim and vigor. I was like, I'm going to change the way healthcare is financed in this country. I'm going to change this, so this is an injustice. We're not going to have it. And the program director was like, well, Samuel, you might want to calm down because this is a very complex issue. All right? And so before you can responsibly work to change how things are done, you first have to understand how things are done. The United States spends a lot of money on healthcare. Last year, we spent $3.3 trillion with a T on healthcare, more than any other country in the world. But how that money is spent and where that money goes oftentimes doesn't go to address the needs of the most vulnerable people in our population. That's a little bit what I want to talk to you about today. I work for pharma, so I'm focusing on mostly how money flows through that pharmaceutical distribution system, or how we spend money in that area. But keep in mind that it's not a trivial amount of money. I mean, what is spent on prescription medicines is about 14% of what we spend totally on healthcare in the United States. Still a lot of money, but it's about 14% of the overall total. So these are some of the terms that we see, like how, there's a very robust commercial marketplace that we have in our country today. We have a system where there's a lot of negotiation on pricing. There's a lot of what we call rebates or discounts, which are negotiated. But a lot of times, as Dr. Pavlovian said, that the patient doesn't really benefit from all of this. These are big boys and big girls who understand the system, who can contract with one another and negotiate the best deal for themselves. But the people within this overall system, which don't have the necessary information to benefit from that, our patients are people or employers who are trying to get the best deal possible for their employees. So I used to price medicines for a living, and so I worked on a paper that we published in last November. It was called Follow the Dollar, which sort of explains how money flows through this overall system. I can make this paper available. It's on our website, but I can send it to Dr. Rios, and anyone who's interested, they can get it. And it goes step by step through and calculates how much money is spent in our system and who gets what, and how each step, how the revenue is calculated. If you're interested, if you want to know this would be a good resource for you to take a look at. It's my paper, so I'd be proud if you did. Yes. But so in this country, when we price medicines, the manufacturer sets a list price for a medicine. All right. I kind of equate that to like a sticker price on a car. You walk into a car dealership, you see a sticker price on the car. Most people typically don't pay that sticker price. That's like the starting point for contract negotiations. Then you negotiate with a dealer and you arrive at a negotiated cost. Okay? That's what the dealer gets, a negotiated cost what the dealer gets. So a consulting firm called Quintiles IMS, which is probably the largest data aggregation consulting firm in the United States for pharmaceutical data, tracked what those prices were for brand medicines in the United States from 2011 through 2016. They'll come out with their new report, I think, in April or May, which will have 2017 numbers on there. But that top line that you see there is a trend for those list prices. They're the ones that manufacturers set and what the growth of those list prices have been. The bottom line represents what we call net prices. Is that after all those rebates and discounts and negotiations took place, how much the net price growth was for brand medicines. So for 2016, you'll see that list prices, which is the ones that the manufacturer set, grew by 9.2%. But after all the rebates and discounts were paid out, the net brand prices only grew by 3.5%. Now, the amount of those rebates and discounts is not a trivial amount. In 2016, IMS reported that those rebates and discounts totaled $127 billion. And the reason we bring that up is what we feel, what pharma feels, and what we've been talking about is, where is that money going? We pay all this money into the overall system, but premiums keep going up every single year. You still have patient out-of-pocket spending is still at an unacceptable high level. You have greater proliferation of high-deductible health plans. So where is that money going? Is enough of it making it way all the way through the distribution system to when we get to the final end user, which are patients and employers, the final payers? Or is it getting or is too much of it getting caught up in that distribution system? So one of the things that we talk this distribution system or supply chain, this is what I'm talking about. The manufacturer makes the medicine, ships it to a wholesaler, who then ships it to the pharmacy, who then dispenses it to the patient. Those green arrows represent the dollar flow between the various entities, and the blue arrows represent the actual prescription flow. So you see the manufacturer makes the medicine, they physically ship it to the wholesaler, who physically ships it to the pharmacy, who then physically dispenses it to the patient. Down below, where you have the PBM, which is the Pharmacy Benefit Manager. I don't know if you guys know, are you familiar with PBM? All right. So they're the people who negotiate with manufacturers on behalf of health plans or employers for prescription medicine net pricing. And the health plan. So the PBM and the health plan don't ever take physical possession of the medicine. It's a financial transaction for them. That arrow that you see from the manufacturer down to the PBM, that green arrow, that is a dollar flow. There's three ways that manufacturers pay the PBM. Manufacturers primarily contract with PBMs, who then contract with health plans. You pay them what we call a base rebate or for formulary access. You want to get on their formulary at the lowest, what we call formulary tier possible. So the lowest tier that the PBM has means the lowest amount the patient has to pay for their medicine. The higher the tier goes, the more money that the patient has to pay. So a tier 1 is typically a generic tier, where patients have to pay about a $10 copay. And as Dr. Poavia mentioned, it's like 90% of all the prescriptions in the United States are generics, or dispensed are generic. So the patient is paying a relatively low cost-sharing amount. Tier 2 is usually a preferred brand, where the patient has to pay a little bit more money. Tier 3 is a non-preferred brand, which is even more money, and then Tier 4 is a specialty tier, which the patient has to pay the maximum amount of money. That's a 4-tier system. There's many systems that are actually even more than that, but that's a simplified way of looking at it. So the manufacturer pays the PBM a rebate to get to the lowest tier possible for a brand medicine, which would be the Tier 2 in an ideal world. They also pay them an administrative fee. Again, that additional formulary rebate is a percentage of the list price of the medicine. They pay them an administrative fee, which is a percent of the list price of a medicine. They also pay them something else called, which very few people are aware of outside of manufacturers and insurers, which is called price protection or inflation protection. It's a stop-loss amount that the PBM has on a list price increase that the manufacturer takes. So they negotiate a percentage increase that a manufacturer can take in a given time frame. So say the manufacturer can take a list price increase of, say, 6% in a year. But the manufacturer takes, say, a 10% increase in that year. Well, that difference, the 10 minus the 6, that additional 4%, has to be rebated back to the PBM. So they have a stop loss on the impact of list price increases. So when you hear in the media, you've heard these examples like this drug Daraprim that Turing Pharma had, or EpiPen, where they took these huge price increases. Now, we don't condone that. Those companies are not members of pharma, and our companies, they don't represent the values of our companies. We don't agree with it or defend those practices. But the underlying fact is, though, that the insurers didn't really experience the impact of those increases because they had a stop loss built in. But the PBM had a stop loss built in, which is that price protection or inflation protection that we saw there. So that represents a dollar flow and what goes up to the patient. Now, you see here, you saw the pharmacy, the PBM, and the health plan. What's happening increasingly in our marketplace is a tremendous amount of consolidation. The PBMs, the top 3 PBMs in the United States, which are Express Scripts, Optum Rx, and CVS Health, or Caremark, which is a subset of CVS Health, which is owned by CVS Health overall. Those 3 PBMs control over 70% of all the prescriptions dispensed in the US today. Tremendous amount of market consolidation. Express Scripts alone covers over 80 million people. It's like the population of Germany, which gives them a tremendous amount of negotiating clout. If you're a manufacturer and your product's not covered by one of those PBMs, you're in a world of hurt. I mean, if your product cannot get access to 80 million people can't get access to your product, that's a problem. All PBMs, that's just one PBM. All of them combined, those are the 3 biggest ones, but all of them combined control the prescriptions for 266 million people in the United States, out of a country of about 320 million people. It's about 83% of the overall population of the US. But what's happening? So you have consolidation within those top 3 PBMs have 70% of the market. But then you've got health plans are owning PBMs. So now like United Healthcare, which is the largest health insurer in the country, owns Optum Rx, which is one of the largest PBMs. Recently you may have heard that Cigna is looking to purchase Express Scripts. So Cigna is one of the larger health insurers, is going to purchase the largest PBM. CVS Health, which owns Caremark, is purchasing Aetna. Okay, and so that's a PBM purchasing a health plan. CVS Health also has over almost 10,000 retail pharmacies. You've got Walgreens Boots Alliance, which is a huge pharmacy chain, purchasing AmerisourceBergen, which is one of the largest wholesalers in the marketplace. They're tied up with Prime Therapeutics, which is a pretty decent-sized PBM, who's owned by 17 Blue Cross and Blue Shield plans. So this is crazy. It's like manufacturers on one side, brand and generic manufacturers, and then you've got this whole system, which is so largely integrated now, where that integration is occurring. And so you sit there and think, wow, the Federal Trade Commission keeps approving these mergers. So they must be thinking this is going to increase efficiencies, right? But what's ended up happening is that as those entities merge and they become bigger and bigger, they are able to get bigger and bigger discounts from manufacturers. But there's so many places for them to hide that spread, that money that they are making from all these particular transactions. So still not enough of it is getting all the way through to the patient. So we talked about how much healthcare spending is growing by. You hear a lot about it in the media. Out of control healthcare, prescription drug spending costs, not healthcare spending, but prescription drug costs are increasing. You hear in the media that prescription drug spending and prices are out of control. In 2016, we saw in the previous slide that brand prices grew by 3.5%. Net after rebates and discounts are taken out. This is spending. And this is all publicly reported. Optum Rx, CVS Health, and Express Scripts are the 3 largest PBMs in the United States. They control over 70% of the scripts. This is what they've publicly reported, that in 2016, Optum Rx said that prescription medicine spending net of rebates and discounts went up by 2.8%. CVS Health said went up by 3.2% in 2016. Express Scripts released 2017 data. They say it went up by 1.5%. The other one we have up here is CMS, which is the Centers for Medicare and Medicaid Services. That's the US federal government. They reported in December for their final 2016 numbers saying that prescription medicine spending went up by 1.3%, net of rebates and discounts. This is a different story than you've heard in the media. All of this is publicly reported. And it's not challenged. The PBMs don't hide this data. They brag about it. They say that, look at a great job that we're doing holding down drug costs. But if they're doing such a great job holding down drug costs, then why is it that premiums keep going up the way they're doing? Because they're telling employers that, hey, your healthcare costs are going up because of prescription drugs. That has been the narrative. Prescription medicines are not the driver of what's going on in healthcare today, but they are. That has been what the discussion has been. I'm not saying there's not a problem. There's a big problem. And that's what I kind of get to in the paper that I worked on, that I did on Follow the Dollar. It's how much patients are having to pay at the point of sale at the pharmacy. Patients pay, when they go to the pharmacy, they pay one of 3 things. They either pay a fixed dollar copay, which is the traditional way that you normally would get your medicine. You go to the pharmacy, you pay your copay, and that's it. Now what's happening is that there's higher and higher high deductible plans. Right? So you go there, so say, until you hit your deductible, you're out of luck. You have to pay the full freight. You can't put this medicine on layaway. You got to pay all of it at the pharmacy counter or you don't get the medicine. So say hypothetically you have a $3,000 deductible, but you're taking a medicine that costs $300 for a list price for a 1 month supply. You walk to the pharmacy and they're like, Mr. and Miss So-and-so, that'll be $300, please. The pharmacist says that. Now the pharmacist has to get that money from you because he's going to be paid from the insurer the cost of the medicine minus what you as a patient are supposed to pay. So if he doesn't collect that money from you, he's out he's out of it. It's coming out of his pocket or the pharmacy's pocket. So they have to collect it from you. So the deductible is $3,000. The cost of medicine is $300 for a month's supply. They're asking you for the full $300. You pay that full $300. So the PBM and the health plan have paid nothing on that claim. But say the manufacturer is giving the PBM a 30% rebate, which they then share with the health plan on that drug. 30% of $300 is $90. So they paid nothing, but they walk away with $90 in the black. So we don't think that's fair. That's like fundamentally unfair. So at least in those type of examples, we feel like, you know what? If the patient's supposed to pay more than the provider, than the insurer, why don't you give that $90 to the patient? At the very least, to lower their cost at the pharmacy counter, to make it easier for them to get their prescription filled. That's what our belief is, all right? But this is really weird because it doesn't work this way in any other part of healthcare. Like say you have that same $3,000 deductible, and you went to the emergency room, all right? And say you had a $1,000 bill at the emergency room. But your insurance company had negotiated a discount with the hospital, so the actually allowed amount of the actual contracted amount was only $600. You'd be required to pay the $600, not the full $1,000 bill charge. It's the same way for a physician visit. It's the same way for a diagnostic test, hospital care, everything except drugs. This is the only area where you have to pay the full amount of the price, not the full list price of the cost of the medicine, instead of the negotiated amount. I know I'm going long, I'm sorry, but I just wanted to hope we can have a conversation about it a bit. But, I mean, we don't think that this is fair, and we think that this is something that needs to be done. So we have a country where 90% of all the medicines are generics, so most people don't have a crazy high amount. I think the stat is about 80% of all people in the country who have to get prescription medicines only have to pay, don't pay more than $20 a month. But that other 20% are the ones who are having an undue burden. They're having to pay a tremendous amount, which is what we feel that insurance is for. That patients are supposed to spread that risk is supposed to be spread out over a large population of people so not too much of a burden comes on any one person. Anyway, this is what we have, and I would love it if we could have some time to have a discussion about this, to answer any questions that you may have. And I will turn it over here.